DSM-3 Personality Disorders, Diagnosis and Treatment by Alan Francis, M.D., Professor of Psychiatry, Cornell University Medical College, and co-editor of the journal Personality Disorders. This is the first cassette in a 4-tape program. It is published by BMA Audio Cassettes, a division of Guilford Publications Incorporated, New York, New York.
Let's discuss the avoidant personality disorder. Actually, this was a controversial addition to DSM-3. In DSM-1 and DSM-2, there was no such disorder. It was introduced largely because clinicians in the psychoanalytic tradition had described a phobic character, and clinicians in the social learning tradition had described people who were socially phobic and inhibited. Some people have felt that avoidant personality disorder just doesn't exist in practice, but I think that's probably because they focus their practice on inpatient settings. If one works in an outpatient clinic or in a private practice and looks for it, avoidant personality is probably one of the more common presentations amongst outpatients. And this is confirmed by a number of systematic studies which now reveal it to be one of the more common of the personality disorders. What does this individual look like? These are shy people. They're frightened of new situations. They're frightened of meeting new people. They don't want to go to parties. They're afraid of entering into relationships without unusually strong guarantees that they will be accepted. If they go to a restaurant, they're likely to go to the same restaurant week in and week out. Maybe select the same table at the restaurant and always order veal parmesan. New things are frightening. At work, these are individuals who often fade into the woodwork. They're frightened of new jobs, new responsibilities, asking for promotions, and so they're often underachievers. They may often not be married despite many talents and abilities that would indicate they'd be desirable mates because they're afraid to ask people out on dates or to be asked out on dates. They present for treatment often with great trepidation. They're just as afraid of the judgments that may fall upon them by the therapist as they are about judgments in everyday life. Often it's only after many years of fretting about whether to begin treatment or not, and many failures in professional and social and sexual encounters, that a patient will present himself for treatment. The most important thing to keep in mind in interviewing a patient with avoidant personality disorder is how frightened they are in the initial contacts. They tend to regard the experience of being in the office with a psychiatrist as yet another potential humiliation. The therapist can be helpful in this regard by pointing out to the patient in subtle ways as he goes along that this particular pattern of behavior and these fears are quite common. The therapist's ability to pick up on the patient's fears, in effect, normalizes the situation. Avoidant patients are very likely to become quite dependent once they do establish a relationship with a therapist. They tend to have so few relationships that are experienced as safe that once they establish a relationship with a therapist, they're very reluctant to let go of it. If the initial contact is a consultation, the consultant must be mindful of how difficult it will be to refer this patient to someone else. They often become quite attached to the consultant and just as fearful of the new person who they might be referred to as they were originally. These patients tend to elicit two types of countertransference reactions in consultants and in therapists. There are those who will tend to push them forward too fast and expect them to do more than they possibly can or feel they can at any given point. This is a great way of losing the patient. On the other hand, some therapists become overly protective and never expect the patient to experience anxiety beyond that which was originally comfortable. Such therapists tend to keep the patient in a cocoon situation, and the therapies, although they may be interesting and seemingly gratifying to both participants, result in minimal change. Well, what are some of the alternative treatment possibilities for the avoidant personality disorder? Now, there's no systematic literature to shed light in this area. There have been no studies on the avoidant personality disorder's response to various kinds of treatment, but there is a fair amount of clinical wisdom and clinical lore that might help guide our clinical decision-making. There's a very large literature on the behavioral treatment for interpersonal avoidance, for shyness, and for social anxiety. A behavioral approach that includes some combination of systematic desensitization of social anxiety, the teaching of new social skills, the exposure to anxiety, and assertiveness training through role-playing, direct instruction, or modeling may be quite useful for avoidant personality disorder individuals. Cognitive techniques that focus on the irrational assumptions and attributions and self-statements of avoidant personality disorder patients may also be very helpful. These patients are constantly expecting the worst from others and seeing the worst in themselves, and this can be teased out through a systematic cognitive approach. These techniques can be very helpful in having the patient face situations that were previously avoided, and facing such situations often leads to benign cycles with an increase in self-confidence and a reduction in demoralization in these individuals. Often I'll begin a cognitive behavioral approach to the avoidant personality disorder patient by having them read this very section in DSM-3. The patient is often surprised by the descriptive clarity of the DSM-3 criteria, sees themselves in the picture described, and feels less alone and less helpless. This then leads us to a discussion of the various things that have been avoided, setting up a hierarchy of feared activities, and developing a plan by which the patient will systematically begin to expose themselves to the various forms of anxiety. In some cases, this will be as simple as going to a beach and wearing a bathing suit, where previously the person was frightened that they would be laughed at because of their body shape. Asking a boss for a raise, asking a girl out for a date. Each of these things may serve as a means of exposing the patient to previously avoided anxiety and can serve a gradual, stepwise effort to no longer be controlled by what were previously irrational terrors. Paradoxical prescriptions are sometimes useful in this regard, especially with those avoidant patients who are also oppositional. The patient's oppositional resistance to change, and these patients often can be quite oppositional, they don't want to move, can be used to psychotherapeutic advantage by prescribing avoidant behavior to the patient in the expectation that the patient will defy the therapist. By telling someone that they've been trying too much and that they should slow down, some oppositional patients will respond to this statement by doing quite the opposite, assuring the therapist that they can do more than they have in the past, and in fact attempting to do more. Another paradoxical approach is to prescribe that the patient seek rejection in a way that is predictable and under control. So that if you take a man who's been frightened to ask a woman out on a date because he may be rejected by her, what you can do is prescribe that in the next week he has to be rejected by 3 different women in order to satisfy the needs of the treatment. If interpersonal rejection becomes an anticipated goal of the treatment rather than a mortifying affront, it changes the whole ballgame. And at times, one can establish 2 tasks, one that will serve as a punishment should the patient not do the first. However, it should be a special kind of punishment, one that's useful, so that the task might be something like one has to be rejected asking 2 or 3 different girls out for a date that given week, and if that's not done, the individual will have to play tennis 2 or 3 times. Playing tennis in itself is getting out of the house and provides for an activity that previously was avoided, so that choosing the lesser evil will in its own way further the patient's ultimate goals and the goals of the treatment. An individual psychodynamic treatment often has much to offer to a patient with avoidant personality disorder, and often these patients are very good at meeting the demands of a psychodynamic treatment. The goal of treatment is the interpretation of the unconscious fantasies that the patient has. Fantasies that impulses will fly out of control in new situations, that the patient will be made a fool of, and lose loved ones by trying to do new things. Patients with avoidant personality disorder often have unrelenting and very harsh superegos. They're very tough on themselves. They expect other people to be very tough on them, and at times they're very tough on other people. This projection of unrealistic expectations of themselves onto others with the expected fear of rejection can be interpreted both within the transference and outside the transference. A complete psychodynamic interpretation for such a patient will identify the unconscious impulse, the fear it evokes, and will trace the avoidant pattern in the transference, in outside relationships, and in the patient's early life experiences. Patients with avoidant personality disorders are often excellent candidates for all types of psychodynamic treatment, and the choice between a behavioral and a psychodynamic treatment, or amongst the various different kinds of psychodynamic treatment, often depends a great deal on the patient's goals and preferences. It's sometimes wise to begin with a more behavioral approach, so that there'll be some fast benefit, and then gradually add more psychodynamic interventions as the treatment progresses. A factor that cuts across the specific techniques that we've discussed is the healing effect of the therapeutic relationship, regardless of the specific techniques that are used in the treatment. Avoidant personality disorder patients learn within the therapeutic relationship, whether it's a therapeutic relationship that's psychodynamic or behavioral or cognitive or interpersonal, that they are acceptable to the therapist and that they need not be frightened by intimate contact. A rule of thumb with these patients is that they have trouble starting treatment, but then they have a great deal of trouble stopping treatment. Often, as we mentioned a bit earlier, often they will remain stalemated in treatments that seem to be wonderful within the sessions, but without apparent progress outside of the sessions. I feel that particularly with patients who meet this personality disorder criterion, it's important that changes occur in their outside behavior that are apparent within the first 3 to 6 months of treatment. No matter how well the session seems to be going, if the patient is not making gains outside of the treatment, doing things they were previously afraid of doing, the treatment's likely to become part of the problem rather than the solution for the problem. This is actually something Freud noted in 1917, that phobic patients really have to face whatever it is they're afraid of. They have to do this both for the purposes of the treatment and also for the purposes of their lives. Patients who meet criteria for avoidant personality disorder are likely to meet criteria for a number of other Axis 1 and Axis 2 disorders. On Axis 1, there's an excellent chance that such individuals will meet the full criteria for one or another of the anxiety disorders. And in fact, it's at least conceivable that avoidant personality disorder might be a spectrum disorder, at least in some individuals, to the anxiety disorders. Such individuals are often depressed and may meet the criteria for dysthymic disorder, for major affective disorder, major depression specifically, or for adjustment disorder with depressed mood. On Axis 2, the most difficult differential and most controversial has to do with the distinction between avoidant personality disorder and schizoid personality disorder. Both individuals are characterized by a similar kind of social avoidance, introversion, lack of contact with other people. The major difference in the DSM-3 definitions of these two disorders has to do with motivation. The avoidant personality disorder patient is alone basically because he or she is afraid of social contact. Such an individual craves the contact, wants it, but is frightened of the consequences, and particularly of the rejections that might follow upon attempts to be close to others. The schizoid individual, as defined in DSM-3, has the same or similar kind of social isolation, but for a different reason. There's less interest, maybe very little interest, or little apparent interest in maintaining social contacts with others. These people are loners because they prefer being alone, not so much because they're afraid of social contact. The consequences of this motivational difference are clear at the extremes of the avoidant and the schizoid personality disorders. So the more prototypal avoidant individual is someone who can develop very close relationships with other people once those people become safe. The prototypal schizoid individual doesn't get close to anyone. However, the distinction is not all that clear, and for many individuals it's difficult to say where on the spectrum they fall. And often, as you get to know the schizoid patient better and better, he begins to look more and more avoidant to you. Avoidant personality disorder individuals are very likely to meet criteria for dependent personality for the reasons we mentioned before, that once they have a safe relationship, they hang on to it for dear life. They're not infrequently able to meet the criteria for passive-aggressive personality. They will stubbornly maintain their avoidance. People have been often pushing them into doing things for their whole lives, and they've learned to maintain a stubborn resistance to such demands. They're very unlikely to meet the criteria for borderline personality disorder for obvious reasons. The borderlines tend to be much more flamboyant than the avoidants, and they're unlikely to meet the criteria for histrionic personality for the same reason. I think the major thing for a clinician to keep in mind about avoidant personality disorder is that it's out there. That if you begin to look for these attributes in the patients you see, particularly in outpatient practice, you will find them quite prominently represented. Also, these are attributes that are probably more treatable than many other personality characteristics, and with a wider variety of treatments, from the psychodynamic to the behavioral, cognitive, interpersonal, paradoxical, and maybe even in some patients the use of medication. So that being mindful of these characteristics, I think, will assist with a number of patients who previously may have been bewildering or difficult to treat. The DSM-3 definition of the dependent personality disorder is probably too narrow, and it consists only of difficulty functioning alone and a tendency to allow others to assume responsibility, thereby subordinating oneself to others and having low self-confidence. The revision of DSM-3 is going to expand the criteria to include such things as remaining in relationships with people who mistreat him or her because of fear of being alone, agreeing with people even when the individual believes they're wrong in order to avoid disturbances in the relationship, difficulty initiating things, a tendency to volunteer to do any kind of unpleasant task just to make people feel attached, a tendency to feel helpless or uncomfortable when the individual is alone, feeling devastated when a relationship breaks up, and a tendency to be preoccupied with the fear of being abandoned and very easily hurt by criticism or disapproval, so that the individual is constantly seeking reassurance or praise. So in other words, the DSM-3 definition as it stands now was too narrowly based, and the effort will be to have the dependent personality disorder a fuller and more complete personality disorder, which really combines two different types of characteristics, one being dependent on others and the other being submissive towards others. These are separable, but they're really combined in the definition, and that probably makes sense. Major controversy about dependent personality disorder is that it's been diagnosed much more often in women than in men. And there are some psychologists, particularly women psychologists, who feel that this is an evidence of sexism in the creation of the diagnostic system, and they may be right. The major point is that women and men express dependency in different ways, whereas women may be submissive, as indicated in the DSM-3 definition. Male dependents, as we discussed in the compulsive personality disorder, may be much more authoritarian in their dependency. There's evidence that when a spouse dies, a man is much more likely to have trouble taking care of himself than is a woman. Moreover, if a person gets remarried, in the man's case, it's much more likely that he'll be remarried in order to have someone take care of him. Whereas in the woman's case, it's more likely that she may get remarried to have someone to take care of. So there's no inherent reason to believe that men are less dependent than women. It's more likely that women and men express their dependency in different ways. And that DSM-3 has focused on the female form of dependency rather than the male form of dependency that we discussed before, with dependence on wife, dependence on secretary, but in a way that doesn't reveal the same kind of submissiveness as is included in the DSM-3 definition. There are two ways of remedying this that have been suggested, neither of which will be included in DSM-3 revision. The first would be to have a male-dependent disorder that would be separate from the female dependent disorder in some way, a kind of autocratic dependency as opposed to a submissive dependency. The other suggestion has been to alter these criteria to include the picture that's more commonly seen in men. The dependent personality disorder overlaps with just about everything under the sun, so that it's a very frequent accompaniment of many of the Axis 2 personality disorders, and it's quite common, particularly in the anxiety disorders. It's probably more common than not that if someone presents with agoraphobia, that they'll meet the criteria, very often meet the criteria for dependent personality disorder. It's very commonly seen in patients presenting with affective disorder. The most common reason for presentation to a therapist for a patient with dependent personality disorder is the loss of the significant other who has been taking care of them. This can be a parent dying, a spouse, or a boyfriend or girlfriend leaving. The patient often looks to the therapist to fill the void that is thus established. These are people who are quite likely to become very dependent on their therapy, very unwilling to give it up. There's no empirical data indicating which of the various forms of treatment one might use is most applicable to patients with dependent personality disorder. But again, there's a wealth of clinical data that's been accumulated over the years. The behavioral cognitive approaches that are most suitable for dependent personality disorder are assertiveness training and exposure to anxiety-provoking situations in which gratification is not immediately forthcoming. So that the most typical assignment for such an individual might be to spend some time alone. These are people who tend to go from relationship to relationship, who've never lived alone, never been able to have a meal in a restaurant by themselves. And a behavioral therapy hierarchy can be established around the patients gradually taking on more and more activities that require their own independent judgment and initiative. There is considerable empirical support for the general effectiveness of assertiveness training, and my guess is that it's probably most effective in this cohort of dependent personality disorder individuals. Cognitive approaches focus on the irrationality of the patient's belief that they can't function alone, that they won't be liked unless they submit to others, and that growing up is something that they just can't manage. The patient's particular social, marital, or familial milieu may also be contributing to dependency, so that treatments that focus on the wider social system are often useful or necessary. Complementary to the dependent woman may well be a dominant, paternalistic, or controlling male, or, for that matter, a dominant, maternalistic, and controlling mother, or both. The other individual may not be consciously keeping the patient down, may not be consciously maintaining or reinforcing dependency, but collusive sex role or family role expectations, overprotection, and discouragement of assertiveness can make it difficult for the patient to alter the personality style regardless of what happens in the individual treatment. So in some cases, the patient may become much more assertive in every situation except the ones that count, with the crucial boss or family member with whom the dependent style is most importantly played out. Marital and family therapy is particularly helpful in identifying and treating such interpersonal systems. And group treatment is particularly useful to avoid the one-to-one dependency that's often established in individual treatment. It's a way of diluting the patient's tendency to pull for protective behavior on the part of the therapist. And it's a way of keeping the patient from putting his or her dependent eggs all in the individual therapist's basket. Now, these are patients who don't want to be in group treatment, who are frightened by it, who feel that they won't be able to function in the rough and tumble of the group environment. And so it's often useful to have a period of individual induction to explain the purpose of this, to build up the patient's confidence, and to gradually undercut the defenses that have them perpetuate the pattern of dependency. A psychodynamic approach explores the fantasies that promote the submissiveness and dependency, and these vary from patient to patient. Some patients will believe that any assertion on their part will kill others or turn others against them, with a resulting loss of love or punishment. Some patients will believe that if they assert themselves, this is a fulfillment of an Oedipal wish, and they feel guilty about such fulfillment. The most common countertransference issue engendered in therapists dealing with dependent personality disorder patients is the guilt that the therapist is not doing enough for the patient. And usually this wears thin after a while, and the therapist becomes annoyed at the patient for expecting too much and for never seeming to be satisfied. Both of these stances interfere with the therapist's ability to confront directly the dependent behavior when this is appropriate, or to gratify it when this is necessary. And we shouldn't underestimate the importance of gratifying dependency, especially during particularly stressful times in the individual's life. If you have a dependent personality disorder patient in the hospital for cancer surgery, and she seems to be requiring an inordinate amount of time from the physicians and the nurses and so forth, the best treatment in that situation is to take care of the patient and to give her the time, not to try to change her personality under those circumstances. And so a flexible therapist has to be able to draw the line at certain points, but at other times gratify the patient when that's really necessary for the patient's coping. Dependent patients will tend to pull from their therapists a complementary overprotectiveness that will serve to maintain their dependent identity and behavior. And then usually the therapist gets annoyed at this and pushes them out too fast. Therapists who are confident about their underlying goodness and nurturing ability are less likely to be caught in the trap of feeling excessively guilty or excessively rejecting. And they won't be excessively giving, nor will they be excessively depriving.
This ends the side.
The compulsive personality disorder is actually one of the oldest. Freud's first contribution to psychoanalytic characterology was the description of the anal compulsives, and he was able to relate what he called the obsessional traits of orderliness, stubbornness, and parsimony with anal eroticism. The compulsive personality disorder is one of the best described and most frequently encountered of personality disorders, perhaps especially in men, and perhaps especially in successful individuals. The DSM-3 definition describes a patient who is perfectionistic, preoccupied with trivial details and rules, stubborn, controlling, restricted to minimal expressions of feeling, conventional, indecisive, excessively devoted to work, and unable to relax. Does that sound familiar to any of you? It's actually difficult to decide at what point one is just an uncommonly hardworking and successful individual. At one point one has gone beyond the pale in this regard. The only real criticism that has emerged about the DSM-3 terminology and the criteria set is its focus on compulsivity rather than obsessiveness. So that the DSM-3 criteria focus on people who are in effect driven and forced to do things. And the emphasis is much less on the obsessional element, which is important in a number of individuals, those who constantly think about things and almost never get them done. PhD candidates are a frequent breed in this regard. The most frequent overlap with another axis 2 disorder is the passive-aggressive. So that the compulsive and passive-aggressive often share an ability to dig their heels in and be impossible to move. And really, in some people, the two conditions are one. Not infrequently, compulsive individuals are also avoidant and manage a very controlled existence in a very narrow and inhibited sphere of life. And not infrequently, they are also quite dependent, although the dependency may be masked. So this is a typical case will be the male executive who's dependent on his secretary for everything during his day at work and dependent on his wife for everything during his day at home. I might mention that I forgot to bring important materials to today's taping and had to have my secretary run across town to bring them to me, which is a fairly typical manifestation of dependency in a compulsive personality disorder. I was very well prepared for today. However, I managed to forget the most important thing. And that, again, is fairly typical of compulsive personality disorder. There'll be a focus on detail, sometimes an exquisite focus on detail, but missing the essential major point that needs to be addressed. The major overlaps with Axis 1 that occur in compulsive personality disorders are with the affective and the anxiety disorders. Compulsive individuals are frequently represented in patients who have unipolar depression and vice versa, and also frequently represented in patients with panic attack and panic attack with agoraphobia. There are no controlled studies indicating which of the various possible treatments available are most effective for compulsive personality disorder, but the clinical literature is very rich in this regard, and a number of different approaches are probably quite helpful depending on the tastes of the individual, the goals of the treatment, and the skills of the therapist. There has been a vast literature on the treatment of Axis 1 compulsive rituals with in vivo exposure. So in other words, if someone has an Axis 1 fear of dirt, getting them to play with dirt and not leaving the field will initially make them quite anxious, but gradually they extinguish to that anxiety. A similar kind of approach can be adapted for use in compulsive individuals, so that having the person be 5 minutes late to work every day during the week, when they've been terrified about being late to work, is often a way of teaching them to tolerate the anxiety that previously they had been avoiding. Shaking up the marbles in one or another way can be a useful behavioral approach if it's done systematically, hierarchically, with the patient's cooperation, and in such a way that they don't get fired. So that it has to be a situation in which the thing that they've been fearing to try doing is done without them suffering terrible consequences. It's much more difficult to treat obsessive ruminators in this regard than it is the more compulsive action-oriented person, just as it is more difficult to treat the Axis 1 obsessive than the Axis 1 compulsive. However, with ruminators, one behavioral approach is to get them to actually make decisions and face the consequences. These are people who will indefinitely delay every decision, and one must convince them that delaying the decision is itself a decision, and usually the worst possible decision, and get them to put up their money and take their lumps. The anxiety of doing this will often be large at the beginning, but just as exposure helps with Axis 1 types of obsessive-compulsive problems, it's often helpful at the personality disorder level as well. Now again, one has to have a patient who's willing to play and who will not be frightened off by a direct behavioral approach. Those people who can't tolerate breaking into the chain of compulsive rituals and obsessive delay may be scared off by a direct behavioral approach, and one may have to be more cautious with them. Cognitive techniques may be useful, particularly for those who are already ruminative. Actually, they may be very useful or terrible for those who are already ruminative, because they may in some people become just another defense, but in others it may be a way of dealing with their style of thinking. Thought-stopping techniques, which have been used for obsessive ruminations, are sometimes useful for the obsessions in compulsive personality disorder individuals. This is something like using a noise or an exclamation to interrupt the rumination. One teaches the patient that when they're ruminating and worrying about the thing over and over again, worrying it to death, that doing something will break that series of thoughts. The success of this method is less well established than the exposure techniques for compulsive rituals, and it's probably true at the personality disorder level as well. Cognitive restructuring can focus on the patient's core irrational belief that thinking everything through will work. These are individuals who terrifically overvalue their thoughts, and one of the things that a therapist can do cognitively is point out that always thinking about things and trying to find out just the right thing will almost always result in the wrong decision. And the most rational way of making some decisions is flipping a coin. This kind of patient will worry most about those decisions that aren't clear-cut, that are uncertain, and where the more one thinks about them, the less likely one is to see a clear way. It's also possible to point out with these individuals how moralistic they tend to be in their thoughts. Everything is should, and they're protected by ruminative intellectualized defenses. Some patients can become aware of the fact that what they previously valued most highly, their ability to think things through, may actually be the problem that they're most presenting with. Paradoxical approaches can sometimes be effective in response to the obsessive personality disorder's oppositional and controlling tendencies. The patient can be told that if indeed he or she is determined to strive for perfection, then this should really be done perfectly and not in a sloppy manner. There should be no allowance for relaxation or pleasure. Patients usually respond to such instructions by paradoxically relaxing more and enjoying things more. This may be because they're opposing the therapist. However, in some instances, it may be because they've gotten the metaphorical point that they can never really be perfect and it's not worth trying. A supportive approach to the obsessive-compulsive personality disorder accepts the patient's compulsive style and works within it to promote optimal coping with the current stress. Suppose we have a business executive who has just suffered a heart attack and is hospitalized. It doesn't make sense at this point to indicate to the patient that he has an excessively controlling style and that he wants to be his own doctor. Rather, it makes great sense to provide such a patient with as much knowledge as one can about his condition, with as much leeway as possible in making the treatment decisions that need to be made. In effect, having the patient join as a consultant on the treatment team. This supports his compulsive defenses rather than confronts them. Psychodynamic approaches have probably been the most used and probably remain the mainstay for most patients with compulsive personality disorder. The major trick here is to avoid encouraging and collaborating with the patient's intellectualized system of defenses, so that the most common error made in the psychotherapy of obsessive-compulsive disorders is for the patient and the therapist to have very, very interesting sessions filled with exquisite detail, often the very fine elaboration of dreams, with the patient's life going nowhere. The patient and the therapist may both be compulsives and may be so involved in playing out the skein of ideas that they miss the interpersonal and affective points of a psychotherapy. Such patients often treat therapy as a job to be performed well, maybe perfectly, or they may resist performing it at all. Sessions may be stilted, boring, unspontaneous, conventional, and controlled. There are ways of getting beyond this. One is that the therapist should try his best to focus his remarks around aspects that do have affect. There are several ways of doing this. One is to ask patients when they cry during the week. And it's striking that a seemingly tight compulsive will often have periods of time, especially at the movies or reading a book or at a concert, in which they cried. Focusing on themes that bring affect to the surface rather than ideas is often quite useful in this regard. These patients will often go into exquisite detail, but exquisite detail that's comfortable. It's useful for the therapist to ask detailed questions about the patient's life in an area that's more affective, more uncomfortable, so that rather than focusing on the speech they gave the day before, focusing on the feelings they had when they went to the bathroom when they made love last night is likely to bring affect to the surface. These are people who feel deeply once one is able to tap the feelings, so that beneath the surface resistances, which are often tenacious, there usually is a person who's capable of a great deal of affect, and if the therapist is alert to this and can find themes of poignancy in the patient's life, this will greatly enliven the session. Humor and teasing is often quite helpful to reduce rigidity and keep the patient off balance. Again, anything can be carried too far and the patient may be offended and quit treatment. The humor is done in such a way that the patient feels that the therapist's heart is not really in the right place. The most frequent countertransference issues are boredom, power struggles, and collusion, intellectual collusion. Psychotherapists are so often themselves compulsive, and I guess if we admit it, we have to say that we also rely on elaborate theories of human behavior that are sometimes obsessive in their concentration on detail, that it's not uncommon for a therapist and a patient to collude in endless theoretical discussions that lead to very little. The therapist is then likely to feel bored or frustrated. He may attempt to inject affect artificially in a way that really doesn't flow at all from the patient's associations. And in addition, as we've stated, compulsive patients can be quite headstrong and controlling, and they may butt heads with therapists who are themselves headstrong and controlling. However, the work with compulsive patients can really be very gratifying. If one is patient at the beginning and is able to establish a relationship with the individual that allows for greater flexibility, for taking chances and for shaking up the marbles, the results can often be amongst the best that we achieve in our work with any type of individual. The passive-aggressive personality disorder was really defined in a very narrow way in DSM-3, and there's been a good deal of controversy about this. In fact, the DSM-3 rules allow that if a person meets the criteria for any other personality disorder, then they should not be given the passive-aggressive diagnosis. It's very likely that this will be changed in the DSM-3 revision, and in fact, the criteria for the passive-aggressive personality have been expanded so that it really cuts a wider piece of the personality disorder pie than was previously the case. These are people who put off things that need to be done. They're constantly procrastinating. It seems like they're always working a little bit slower than you think they should be working, especially if they're working for you. And this is especially the case if the individual is doing a job that they don't like and don't want to be doing. The passive-aggressive individual constantly complains and feels that unjustifiable demands are being made on them, and that it's unreasonable to expect as much as the world and their bosses seem to expect, or spouses seem to expect from them. These are people who seem to forget a lot when they have a responsibility. So it's the husband who forgets that it's his wife's birthday, and even though all day he was planning on getting flowers for her, never winds up actually buying them. Passive-aggressive individuals tend to be sulky and irritable and argumentative. They tend to see the worst in everything, pessimistic about themselves and about others. And they often feel that they're doing a much better job than the people around them feel that they're doing. And so they're surprised when bosses complain about their work or give them less than exemplary evaluations. The passive-aggressive personality disorder shares a number of characteristics with patients who will meet criteria for other Axis II diagnoses. Most particularly, there's a sharing with the dependent, the avoidant, and the masochistic patient, an unassertive and at times submissive interpersonal style. However, the one thing that distinguishes the passive-aggressive individual is the fact that the submissive style is often quite deceptive, and underneath there's an iron oppositional will which expresses itself in all kinds of subtle ways. Such patients present for treatment quite often with depression and or anxiety disorders, so that one might expect one might be careful to make sure that a major affective disorder or an adjustment disorder with depressed mood or an anxiety disorder is possibly also present in such individuals. Generally, the precipitant will be a problem with someone else, so that it's very rare for someone with a passive-aggressive personality disorder to spontaneously realize that they have such a disorder and to present for treatment to change such a disorder. Most commonly, they arrive for treatment having had a bad job evaluation or having a wife or a husband who is ready to leave them unless they change. And usually they feel quite put upon and will attempt to use the treatment as a way of justifying their own behavior, so that the early steps in treatment will require a careful assessment with the patient of those aspects of his or her behavior that may be contributing to the trouble. The therapist and the patient must agree that there's a problem before they'll be able to explore the underlying reasons for that problem or develop a strategy for changing the behaviors in question. There's been no systematic research on the treatment of passive-aggressive personality disorder, but there are a number of clinical suggestions that come both from the behavioral and the psychodynamic and the paradoxical clinical literatures. The behavior therapies focus on social skills and assertiveness training via role-playing, direct instruction, and modeling. The basic notion is that if the passive-aggressive individual has a way of assertively getting his way, he will not have to use the oppositional, covert, and passive-aggressive mechanisms that previously seemed necessary. The cognitive therapies focus on the irrational logic and assumptions that underlie passive and resistant behavior, so that the patient is shown that their sense of being constantly put upon by people who don't really seem to appreciate them is probably exaggerated if it occurs in a wide variety of social contexts with a number of different people. And their own contribution and the automatic thoughts they have that the world is really expecting too much are highlighted, usually using day-to-day diaries that focus on each episode where the patient feels that something has been done that wasn't fair or too much has been expected. The passive-aggressive patient will often resist the therapist as yet another external authority. At times, the treatment will be a power struggle that very much resembles the power struggles that patients have had outside the treatment. Some patients will be capable of seeing this resemblance and beginning to try to understand it. For other patients, a more supportive approach is necessary. The therapist may have to accept the fact that the patient must engage in power struggles, and that the therapist must play his or her part without becoming excessively guilty, angry, or withdrawing. Paradoxical approaches are often useful in this regard, again by capitalizing on the patient's oppositionalism. The therapist may prescribe behaviors that are more or less opposite to the ones that would be therapeutically desirable. If the patient is focused on resisting the advice or authority of the therapist, then the therapist can side with maladaptive behavior, and in order to prove that the therapist is wrong, the patient may, in fact, paradoxically, do that which is more healthy. For instance, for a patient who's been avoiding work or coming late to work, the therapist may congratulate the patient for showing good judgment in not extending himself or herself excessively. The advantages of not working can be extolled in detail, conveying to the patient that the only real way to defeat the therapist is to get a job or be on time for jobs. The psychodynamic approach explores the underlying dependent, aggressive, and narcissistic fantasies that underlie the peremptory need for a negativistic autonomy. Assertion can be avoided because it symbolizes an Oedipal triumph, or is regarded as a trigger for retaliation. Passive-aggressive behavior also often provides a great deal of sadistic and masochistic gratification. Passive-aggressive patients are often both afraid of and desire to be totally cared for, taken over by others. And they're sometimes able to reduce their oppositionalism once they are aware of its role in controlling their underlying dependency needs. These patients need to see that they are ultimately responsible for their failures and frustrations, and to reclaim the anger that is hidden behind their superficial submissiveness. Passive-aggressive patients are amongst the most annoying to treat, and are probably greatly overrepresented in all forms of treatment failure, both in psychiatry and in medicine. The therapist will have a chance only if he or she has little need to win power struggles, but is willing to participate in them when this is necessary. So it requires a flexible therapist who doesn't have to fight, but who can fight in a kind of fair and loving way in order to maintain a relationship with a patient who knows no other form of closeness. The therapist must generally resist the interpersonal pull to do battle, as this will usually serve to maintain the passive-aggressive stance and stimulate complementary hostile dependency, so that the usual course of events is that at the beginning of treatment, the therapist and the patient may slug things out, but then gradually the therapist fights less, and the hope is that this helps the patient to learn that there's a way to be that doesn't require such battles. The most serious countertransference problems occur in those therapists who are either authoritarian themselves and eager to encourage submission in those around them, or in those therapists who are excessively unassertive. The former are likely to become trapped in power struggles, and the latter are likely to passively stand by as the patient's resistant behavior eventually leads to an early termination or to a negative therapeutic reaction. This latter possibility is one of the most troubling of the possible outcomes in the treatment of any kind of personality disorder patient. For those therapists who have great therapeutic zeal and need to make their patients better, some passive-aggressive patients will go to fairly considerable lengths to get worse. And so one must be alert to the possibility that some such individuals will actually do worse in therapy than they would do with no treatment at all. And at times it's useful to recommend at least a vacation for treatment for someone who has a pattern of engaging in such self-destructive, repetitive oppositional battles with therapists.
This ends Tape 1.